Sciatica is a condition where there's pain that starts in the lower back, which then travels down the leg. Since the pain is associated with injury or compression of the sciatic nerve and follows the path of the sciatic nerve, it makes sense to name it sciatica. The sciatic nerve is the longest and widest nerve in the body. It's formed by the spinal nerves L4, L5, and S1, 2, and 3, which leave the spinal canal through the intervertebral foramen, an opening located between the vertebrae and behind the intervertebral discs. These nerves travel to the area in front of the sacrum and join to make the sacral plexus. All the nerves in the plexus except S3 are split into two divisions, anterior and posterior. Anterior divisions of the L4, L5, S1, S2, and the entire S3 nerve create the tibial nerve, while posterior divisions of the L4, L5, S1, and S2 form the common fibular nerve. These two nerves are bound together by connective tissue and make up the sciatic nerve. The sciatic nerve then passes beneath the piriformis muscle and through the greater sciatic foramen, which is an opening formed by the pelvic bone, sacrospinous, and sacrotuberous ligaments. It then travels down the back of the thigh to the back of the knee, where it splits into the tibial and common fibular nerves. The sciatic nerve innervates the muscles in the back of the thigh. The tibial nerve innervates the muscles of the posterior compartment of the leg and intrinsic flexors of the foot. The common fibular nerve is in charge of the muscles in the anterior and lateral compartments of the leg and intrinsic extensors of the foot. Now, each spinal nerve is in charge of the sensation of a specific area of the skin, called a dermatome. Dermatomes of the spinal nerves of the sacral plexus cover almost the entire surface of the thigh, leg, and foot. L4 covers the medial side of the leg, L5 covers the lateral side, S1 covers part of the dorsum and the entire sole of the foot, S2 covers the back of the leg, while S3 covers the back of the thigh. Skin sensations like touch, temperature, pain, and pressure are carried to the spinal cord and then to the brain where we register the sensations. Sciatica occurs when there's irritation to any part of the sciatic nerve or the spinal nerves that form it. The causes of sciatica can be divided into two groups, spinal and non-spinal. Spinal causes are related, obviously, to the spinal column. The most common one is intervertebral disc herniation. The intervertebral discs lie between vertebrae and act as shock absorbers. Each disc is made of two parts, the outer fibrous ring, called the annulus fibrosus, and the inner gel-like pulp, called the nucleus pulposus. Poor posture, traumas, physical activity, and strong rotational movement can cause herniation where the disc bulges out in one direction. If it bulges out towards the center of the spinal cord, it could compress multiple nerve roots on both sides, or laterally, compressing one nerve root on one side. In some cases, the nucleus macrophages attack the nucleus pulposus and start secreting inflammatory cytokines, like tumor necrosis factor alpha and interleukin 1 and interleukin 6. The inflammation and swelling which result from this reaction compresses the nerves even further. Another cause of nerve compression is spinal stenosis, which is the narrowing of the spinal canal or intervertebral foramen. This is often due to degenerative disorders of the bone, trauma, or inflammatory diseases like rheumatoid arthritis. Spondylolisthesis is a condition where one vertebra slips or becomes displaced due to a trauma, surgery, or degenerative spinal disease and presses on the nearby nerve roots. Finally, any growths within the spinal canal, like tumor, cysts, or abscesses, can cause compression of the spinal nerves. Non-spinal causes occur outside of the spinal region and cause compression or damage to the sciatic nerve itself. The most common one is piriformis syndrome. The piriformis muscle and sciatic nerve are very close to each other. So, if the piriformis muscle gets irritated, it can cause muscle inflammation or muscle spasms that can compress the sciatic nerve. A more recent phenomenon is the so-called wallet sciatica, or credit carditis. Many people carry their wallets or other objects in their back pockets. So when they sit down, these objects put pressure on the gluteal muscles, which compress the sciatic nerve, causing sciatica. Pregnancy is another potential cause of sciatica. When sitting, the fetal head presses down on the sciatic nerve, on the area just before it exits the pelvis. Other non-spinal causes include trauma to the leg and pelvic tumors, which can damage or compress the nerve directly. In sciatica, the main symptom is aching and sharp leg pain. It radiates along the middle or lower buttock, and on the back or the outer side of the thigh. Below the knee, the pain usually follows the dermatome distribution. For example, if the L4 nerve root is compressed, the pain would radiate alongside the medial side of the leg. If the S2 nerve root is compressed, the pain would mostly be felt along the back of the leg. This pain could begin suddenly, usually with disc herniation, piriformis syndrome, or trauma. It could also develop slowly, like if it's caused by a tumor or spinal stenosis where the pain increases over time. Sciatic pain is typically unilateral, meaning it's only located on one side. Bilateral sciatica, where both legs are affected, can occur with central disc herniation, lumbar stenosis, or spondylolisthesis. Sometimes the pain can be accompanied by other sensory or motor dysfunctions like numbness, motor weakness, and reduction or loss of reflexes. S1 spinal nerve compression affects the ankle jerk reflex, while L4 nerve compression affects the knee jerk reflex. To diagnose sciatica, there are some classic physical exam findings. The Lessegs sign, also called the straight leg raise test, is most often used to check for spinal causes. In this test, a person lays down on their back and an examiner lifts each leg with the knee straight. This stretches the nerve roots over the herniated disc or the object causing compression. If the sciatic pain worsens when the legs are between 30 and 70 degrees, the test is positive. Finally, a CT or MRI should be done to look for the cause. Sciatic pain caused by inflammation often resolves on its own over time. With pain medication and anti-inflammatories, the pain can be relieved in a few weeks to a few months. Surgical treatment is required if the sciatica was caused by tumors, cysts, abscesses, or injury to the spinal cord. Alright, as a quick recap. Sciatica refers to aching and sharp leg pains that radiate below the knee. It is caused by irritation or damage to the sciatic nerve and spinal nerve roots of the sacral plexus, most commonly as a result of disc herniation. Typically, the pain resolves on its own over a few weeks to months, but sometimes surgery is required.
The menisci are crescent-shaped fiber cartilage cushions found in the knee joint. Normally there's the medial and lateral menisci between the femur and tibia, so a meniscus tear, more commonly known as a torn knee cartilage, is when one of the menisci of the knee is torn. This usually occurs during a trauma during contact sports. The knee is a complex joint. Actually, it's a combination of three joints. These are the femoropatellar joints, between the femur and patella, and the two tibiofemoral joints, which are formed by the bony prominences also called the condyles of the tibia and femur. Between the femoral and tibial condyles, there are the medial and lateral menisci. The menisci act to absorb compressive force, which can reach up to 3 times the body weight while walking. In addition, the menisci have a cup-shaped surface which provides a deeper place for the condyles to fit in improving joint stability. Next, the knee joint is supported by a number of ligaments. So within the joint space, there is the anterior cruciate ligament, or ACL, which runs from the anterior middle edge of the tibia to the lateral condyles of the femur, and the posterior cruciate ligament, or PCL, that runs from the middle posterior edge of the tibia to the medial condyle of the femur. Now, outside the joint space, we've got one collateral ligament between the femur and the tibia on each side of the joint, which are the lateral collateral ligament, or LCL, and the medial collateral ligament, or MCL. The MCL is firmly attached to the medial meniscus, which makes it less mobile compared to the lateral meniscus. A meniscus tear can occur when the meniscus is violently compressed, called an acute tear, which usually occurs in young athletes. Acute tears typically occur when the knee is bent and at the same time excessively twisted, like when you're playing basketball and then you suddenly change direction, trying to cross over another player. Acute meniscus tears can also occur as part of an unhappy triad injury.
This is where a lateral force to the knee, like when the knee is hit by a hockey puck, causes tears in the ACL, MCL, and one of the menisci. Now, regarding which of the menisci, it's worth mentioning that even though the classic unhappy triad consists of the ACL, MCL, and medial meniscus tears, the lateral meniscus is more commonly injured than the medial. This is because when the knee is affected by a blow from the lateral side, the lateral meniscus gets compressed between the tibia and the femur, leading to injury.
In contrast to an acute tear, there are also chronic tears, which usually occur in older people. This is because the wear and tear of the menisci make them more susceptible to tears with minimal force, or any noticeable trauma. An elderly person might tear their meniscus from simply getting up from a chair. Alright, let's talk about symptoms. In an acute tear, there can be an intense pain in the joint at the time of trauma. Over the next 24 hours, joint pain and swelling increase gradually. In addition, a piece of the torn meniscus can get stuck between the condyles, restricting joints movement called joint locking. This causes a clicking sound or a popping sensation when trying to extend the knee. In contrast to acute tears, pain in chronic tears can be absent. However, mechanical symptoms like joint locking or popping sensation can still be present. The diagnosis of meniscus tear is mainly based on clinical symptoms, in addition to testing knee joint range of motion and any associated pain. One of the tests used to do that is McMurray test, where the knee is bent, internally rotated, and then extended in order to compress the lateral meniscus. If the person feels pain while extending the knee, there's likely a lateral meniscus tear. The same is done to diagnose a medial meniscus tear, where the knee is bent, externally rotated, and then extended to compress the medial meniscus. An X-ray can't directly show a meniscus tear, but it can show degenerative changes in the joint, like those in osteoarthritis, which are commonly found in cases of chronic tears. Examples of osteoarthritic changes are joint space narrowing, osteophytes formation, which are small bony projections in subchondral sclerosis, which means hardening of the bones that underlie the joint cartilage. However, the diagnosis of acute and chronic meniscus tears can be confirmed using an MRI, which will not only show the tear, but also the size and location. The treatment of meniscus tear begins with ice to reduce inflammation, rest, and pain medication. Also, physical therapy can strengthen the muscles around the knee, which helps decreasing the load on the menisci. In more severe cases, open or arthroscopic surgery may be needed to repair the torn meniscus. Alright, as a quick recap, meniscus tear is when one or both of the menisci of the knee joint are torn. Acute tears usually occur in athletes during contact sports, when the menisci are violently compressed. On the other hand, chronic tears occur in older people and are due to wear and tear changes of the menisci. The diagnosis is mainly based on clinical symptoms, like knee pain and swelling, and can be confirmed by MRI. Treatment can be conservative, or by open or arthroscopic surgery.
Acute compartment syndrome is a surgical emergency that occurs when muscle compartments, which are bounded by non-compliant fascial membranes, have an increase in pressure, causing tissue ischemia. Although it's usually associated with extremity trauma, Any condition that increases intracompartmental pressure can lead to compartment syndrome. Acute compartment syndrome is typically a clinical diagnosis, but you can confirm the diagnosis of unclear cases with a direct measurement of compartment pressures. Compartment syndrome can lead to irreversible tissue damage requiring amputation without rapid diagnosis and surgical decompression by fasciotomy. When assessing a patient with signs and symptoms suggestive of acute compartment syndrome, first perform an ABCDE assessment to determine if the patient is unstable or stable. If the patient is unstable, start acute management immediately to stabilize their airway, breathing, and circulation. This means that you might need to intubate the patient, obtain IV access, begin fluid resuscitation, and monitor their vitals before continuing with your assessment. Once this important step is complete, obtain a focused history and physical exam, as well as labs like CBC, CMP, CPK, and lactate. Now, let's first look at history. The patient might present with ongoing severe extremity pain, swelling, and rapid progression of symptoms over a few hours. You can also suspect some causes of acute compartment syndrome based on history. The patient may have a known history of extremity trauma, such as a fracture, burn, or crush injury. They might have a history of prolonged ischemia with reperfusion, such as a recent surgical revascularization procedure. Other causes include extended immobility or extreme exercise, which can lead to rhabdomyolysis, and even massive DVT like phlegmasia ceruleus dolens. Okay, the exam may reveal tachycardia and hypotension, as well as a tense wood-like muscle compartment on palpation, motor paralysis, and sensory loss. Physical exam findings can also include skin changes like pallor or mottling, as well as poikilothermia, or skin that is too cold to the touch, and as a late sign, weak or absent extremity pulses. Additionally, a key sign that's considered compartment syndrome until proven otherwise is pain in the leg with passive stretching of the muscles, such as pain in the leg with passive dorsiflexion of the foot. It is important to always perform a thorough neurovascular examination of the affected extremity because after more than 6 hours of ischemia, tissue damage can become irreversible. Signs of severe ischemia include foot drop from peroneal nerve injury or Volkmann's contracture in the arm, which results in a claw-like deformity of the hand. If tissue necrosis has already occurred, a secondary soft tissue infection may also be present. Here's a clinical pearl. The lower leg consists of 4 muscle compartments: anterior, lateral, superficial posterior, and deep posterior. However, the deep posterior compartment cannot be palpated on physical examination. Finally, labs might reveal leukocytosis, electrolyte abnormalities such as hyperkalemia, and in some cases, even evidence of acute kidney injury, such as an elevated BUN to creatinine ratio, as well as an elevated CPK. Lactate can also be elevated since it's released by damaged cells. If you see these signs and symptoms, you can diagnose acute compartment syndrome. Now that the diagnosis is made, let's talk about treatment. Compartment syndrome is an emergency, so the first thing to do is call the surgical team for consultation. Then, immediately start with supportive care, which includes IV fluid resuscitation, correction of electrolyte abnormalities, broad-spectrum antibiotics, supplemental oxygen, and pain management as needed. Once ready, the surgical team will perform emergent fasciotomy. Finally, treat the underlying cause if found. Okay, now that the unstable patients are taken care of, let's return to the ABCDE assessment and talk about stable patients. Your first step here is to obtain a focused history and physical exam, as well as labs like CBC, CMP, CPK, and lactate. Now, history and labs are usually similar in all patients with compartment syndrome. The history might reveal pain, paresthesias, such as pins and needles sensations or numbness, and rapid progression of symptoms over a few hours. As before, patients might report traumatic injuries, such as fractures, burns, crush injuries, or even a new constrictive cast or bandage. You should also look out for other causes, such as animal bites and stings, prolonged ischemia and reperfusion, spontaneous hemorrhage or hematoma, and even extravasation of IV fluid, medications, or drugs. On the flip side, labs typically reveal leukocytosis, electrolyte abnormalities such as hyperkalemia, and elevated CPK and lactate. Now, the real difference in presentation is the physical exam. Some patients might present with clear findings of compartment syndrome. In this case, the physical exam reveals pain out of proportion to physical findings, extremity swelling, a tense wood-like muscle compartment on palpation, and pain to passive stretch. They may even have motor or sensory deficits, depending on the duration and severity of the limb ischemia. If you see these clear findings, you can make a clinical diagnosis of acute compartment syndrome. As before, since this is an emergency, call the surgical team for a consult and possible fasciotomy. At the same time, start supportive care, including IV fluids and supplemental oxygen. Take steps to maximize tissue perfusion, such as with limb elevation to the level of the heart. Now, this will decrease arterial blood flow, but it will also increase venous drainage and decrease swelling and help relieve pressure, as well as removing or relieving any external constriction like casts or bandages. Finally, administer analgesics if needed for pain management. Once again, remember to treat the underlying cause. Now, let's go back to the H&P and discuss patients who present with inconclusive findings of compartment syndrome. In this case, the physical exam might only reveal leg swelling, absent or mild pain to passive stretch, and no motor or sensory deficits. Exam findings might also be inconclusive in patients who are unable to participate in their physical exam or reliably express how they're feeling. If this is the case, you might suspect acute compartment syndrome. You should initiate the same supportive care with IV fluids, supplemental oxygen, limb elevation, removing or relieving external constriction of the limb, and pain management. Once supportive care is started, measure the compartment pressure to confirm your diagnosis. Here is a clinical pearl. There are several ways to obtain a compartment pressure reading. There's a special handheld manometer made just for this purpose. However, if you don't have one readily available, you can create your own manometer by attaching an 18-gauge needle to an arterial line setup to measure compartment pressures. Alright, now that you have measured the compartment pressure, let's talk about the results. If your patient's compartment pressure is greater than or equal to 30 millimeters of mercury, or if the delta pressure, which is the difference between the compartment pressure and the patient's diastolic blood pressure, is less than or equal to 30 millimeters of mercury, then you can diagnose acute compartment syndrome. If this is the case, call the surgical team for an emergent fasciotomy. As before, remember to treat the underlying cause. However, let's say you measure the compartment pressure and the absolute value is less than 30 millimeters of mercury, and the delta pressure is more than 30 millimeters of mercury. At this point, continue to closely monitor the patient hourly, or even more frequently if needed, with serial extremity or compartment exams, and assess their response to supportive care. Don't limit your exam to simply palpating the muscle compartments of concern. Always perform a thorough neurovascular exam too. Next, assess the patient's response to treatment. If the patient has an adequate response, where symptoms and exam findings improve over the next several hours to days, you can rule out acute compartment syndrome. Go ahead and continue supportive care and treat the underlying cause. Okay, let's switch gears and talk about patients with inadequate response to treatment. If the patient's symptoms or exam findings are worsening, you should immediately remeasure the compartment pressure. All right, if the repeat compartment pressure measurement is now greater than or equal to 30 millimeters of mercury, or if the delta pressure is less than or equal to 30 millimeters of mercury, you can diagnose acute compartment syndrome. At this point, call the surgical team for an emergency fasciotomy and be sure to treat the underlying cause as well. Finally, if the repeated compartment pressure measurement is still less than 30 millimeters of mercury or the delta pressure is over 30 millimeters of mercury, consider an alternative diagnosis. All right, as a quick recap, acute compartment syndrome is a surgical emergency. Unstable patients should be rapidly assessed and treated surgically, as the extremity might not be viable. On the other hand, stable patients may present with findings on physical exam that indicate compartment syndrome. When the clinical diagnosis is clear, such as a patient with a tense, wood-like compartment and pain to passive stretch, immediately call for a surgical consultation for an emergency fasciotomy and treat any underlying causes. However, if the exam findings are inconclusive, measure the compartment pressures directly. If any compartment pressure is greater than or equal to 30 millimeters of mercury, or if the delta pressure is less than or equal to 30 millimeters of mercury, call a surgical consult for a fasciotomy and treat any underlying causes. When the clinical diagnosis is clear, such as a patient with a tense wood-like compartment and pain to passive stretch, immediately call for a surgical consultation for an emergency fasciotomy and treat any underlying causes. However, if the exam findings are inconclusive, measure the compartment pressures directly. High compartment pressure or low delta pressure requires fasciotomy. Normal compartment pressure and delta pressure should be managed with supportive care and hourly reassessment.
With compartment syndrome, compartment refers to separate sections of the body that contain muscles, nerves, and blood vessels surrounded by a layer of fibrous connective tissue. When the pressure within these compartments rises, normal blood flow can be cut off, leading to tissue damage due to hypoxia or the lack of oxygen. Compartment syndrome typically happens in the limbs, usually in the lower leg or the forearm. Now, if we remove the skin and then we remove the fat from the lower leg, we would uncover the fascia. Fascia surrounds the muscles, keeping them tightly together while they contract to move the limb, and it also helps attach these muscles to the bones. Now, if we look at a cross-section of the lower leg, we can see that the fascia sends intermuscular septa that, together with the interosseous membrane between the tibia and fibula, divide the lower leg into 4 compartments. The anterior, lateral, deep posterior, and superficial posterior compartments all contain their own muscles and blood vessels. For example, the anterior compartment holds the muscles that perform dorsiflexion of the foot and also aid in its inversion and eversion. The deep perineal nerve that innervates them and its blood supply come from the anterior tibial artery and veins. Since the fascia is not elastic, it can't stretch much. Therefore, any increase of the cellular and extracellular volume, or a decrease of the volume capacity, like with some external compression, will lead to the increase of the pressure inside the compartment. This will compress the structures within, and the first ones to feel the effect of compression are the veins, because the pressure inside their lumen is normally low. As the pressure increases, the arteries will become compressed next, and this obstructs the normal blood flow. This cuts off the oxygen supply and hypoxia develops, which causes cells to start releasing substances like histamine and nitric oxide. These substances cause capillaries to become leaky, so fluid leaks out, causing extracellular edema that further increases intracompartment pressure. Okay, let's look at the muscle cells. Hypoxia prevent their mitochondria from producing adenosine triphosphate, or ATP, which is the cell's main source of energy. Inside the cell membrane is a sodium-potassium pump that needs ATP in order to pump sodium out of the cell and potassium inside. So without ATP, there's an increase in intracellular sodium levels, which cause water to move into the cells, causing intracellular edema. If hypoxia lasts too long, intracellular edema can lead to cell membrane rupture, causing proteins to leak out into the extracellular space. These proteins draw more water from the capillaries, and we get a vicious cycle of increased compartment pressure, tissue hypoxia, edema, followed by cellular death, and even more pressure. The most common cause of compartment syndrome is bleeding inside the compartment. This typically occurs with long bone fractures, like the tibia or the forearm bones, and penetrating wounds or surgical procedures that injure blood vessels. Other causes are swelling of the tissue after severe burns, intravenous drug injection, repetitive use of the injured muscles, or a vigorous muscle contraction like in tetany or seizures. Any limb compression, like from a crush injury or from an inappropriately placed cast, can also lead to compartment syndrome. Another potential cause could be reperfusion injury. This occurs with the reestablishment of normal blood flow to hypoxic cells. These cells stop producing proteins, like antioxidants. So providing them with oxygen again can actually lead to the formation of toxic reactive oxygen species that they can't get rid of. Signs and symptoms of compartment syndrome can be remembered as the 6 Ps, which are pain, paresthesia, pulselessness, pallor, poikilothermia, and paralysis. The most common is pain, which is usually described as sharp and deep, and worsens with passive stretching of the affected muscles. Pain is followed by paresthesia, which is an abnormal sensation like feeling of pins and needles or numbness that can even progress to anesthesia or a loss of sensation. The other 4 Ps are less common, as pulselessness appears only when the compartment pressure is so high that it makes the arteries collapse. Then a pallor of the skin can appear together with poikilothermia, which is the inability to regulate body temperature and usually presents as cold extremities. Paralysis is rare and suggests extensive damage to both the muscles and nerves. Complications such as necrosis can occur when normal blood flow is not established in time, leading to tissue death due to the lack of oxygen. For example, necrosis of the flexor muscles of the forearm leads to their fibrosis and shortening, which results in permanent flexion of the wrist and hand, known as Volkmann's contracture. Another complication is rhabdomyolysis, where muscles break down. Muscle proteins, like creatine kinase and myoglobin, start leaking out into the bloodstream. Myoglobin is especially toxic for the kidneys and can cause acute renal failure. Diagnosis includes physical examination, where the affected group of muscles appears stiff, firm, and feels hard like wood. The individual complains of pain that worsens with passive stretching of the muscles. The best diagnostic tools are the intracompartmental pressure monitors that can be inserted directly inside the compartment. When rhabdomyolysis develops, a laboratory workup can show elevated levels of creatine kinase and myoglobin, while urinalysis can show tea-colored urine due to high levels of myoglobin. Imaging techniques like radiography, CT, MRI, and ultrasound can help locate bone, muscle, and blood vessel injuries. Treatment is surgical and involves a procedure called fasciotomy, where the fascia is cut open, relieving the pressure and re-establishing normal blood flow. Fascia can be left open for a few days until the cause of increased pressure is treated. When the compartment syndrome is caused by some external factors, like an inappropriate cast, its removal can result in spontaneous recovery, and the surgery may not be needed. Alright, as a quick recap. Compartment syndrome refers to the increased pressure inside the section of the limb that contains muscles, nerves, and blood vessels, and results in the reduction of blood supply and tissue necrosis. It usually develops in the lower leg and forearm after traumas like a bone fracture. If not treated in time, it can lead to permanent muscle and nerve damage.
Carpal tunnel syndrome is a nerve entrapment disorder that results in the compression of the median nerve, which winds its way through the wrist through a narrow passageway called the carpal tunnel. This compression typically causes pain, numbness, and tingling in the thumb, index finger, middle finger, and thumb side of the ring finger, which are the areas of skin innervated by the median nerve. Now, taking a cross-section of the wrist, we'll see a bony arch known as the carpal arch, on the dorsal side of the hand, which forms the floor of the carpal tunnel, and a sheath of connective tissue called the flexor retinaculum, or transverse carpal ligament, which is on the palmar side of the hand and forms the roof of the carpal tunnel. Also, there are 9 flexor tendons, which go to the fingers and the thumb, as well as one nerve, the median nerve, which travels down the forearm and goes through the carpal tunnel. The skin of the hand served by the median nerve includes the thumb, the index finger, the middle finger, as well as half of the ring finger that's on the thumb side. The other side of the ring finger and pinky are served by the ulnar nerve, and the back of the hand served by the radial nerve. Only the median nerve goes through the carpal tunnel. Carpal tunnel syndrome is caused by compression of the median nerve, and that typically happens as a result of inflammation of the nearby tendons and tissue, which creates local edema or swelling, which increases the amount of fluid in a very tight space, and essentially puts pressure on the median nerve. Initially, that pressure can cause a dull ache or discomfort in any of the areas of the hand that are innervated by the median nerve. Eventually, this discomfort can lead to sharp pins and needles-like pain, called paresthesia, which can extend up the forearm. People might also have muscle weakness, which can cause clumsiness with tasks like holding small objects, turning doorknobs and keys, or fine motor tasks like buttoning up a shirt. In severe situations, the thenar muscles at the base of the thumb can start to waste away. This happens because those muscles are innervated by the recurrent branch of the median nerve, which arises from the median nerve after it passes through the carpal tunnel. Basically, in a nutshell, any structure innervated by the median nerve downstream of the point of compression can be affected. Interestingly, a superficial sensory branch of the median nerve, called the palmar branch, provides sensation to the central base of the palm. Because this nerve branches upstream or proximal to the carpal tunnel and travels superficial to it, this nerve's not affected by carpal tunnel syndrome. And this is also why there's no loss in sensation in the central palm of the hand. Typically, in carpal tunnel syndrome, both hands are affected because usually there's a repetitive stress injury, like typing, which causes inflammation in both wrists. This also explains why symptoms of carpal tunnel syndrome tend to be worse at night, after a day of use. Other risk factors of carpal tunnel syndrome include obesity or pregnancy, as well as having underlying conditions like rheumatoid arthritis, where there's joint inflammation from an autoimmune process that leads to the compression of the median nerve. Diagnosis of carpal tunnel syndrome can be made based on electrophysiological testing, description of symptoms, as well as physical tests. For example, Phelan's maneuver, where you flex the wrists as far as possible and then hold that position for a minute, results in numbness in the areas of the hand innervated by the median nerve in people with carpal tunnel syndrome. Another physical test, Tinel's sign, is performed by tapping the transverse carpal ligament, which reproduces the symptoms of tingling or feelings of pins and needles in areas of the hand served by the median nerve. Finally, there's Durkin's test, which is another way to elicit carpal tunnel symptoms, but this time by manually compressing the carpal tunnel with the thumb for 30 seconds. One major form of treatment is behavior modification, many of which are associated with hand positions while typing, which is a common cause of the problem. Changes like keeping the axis of the hands parallel to each other and the table, using a computer mouse instead of a trackpad, and wearing wrist supports and splints while typing can all be super helpful. Physical therapy in the form of stretching and isometric exercises can also help relieve symptoms. In more serious cases, it might be treated non-surgically by splinting or corticosteroid injection, but the definitive management often requires surgical division of the transverse carpal ligament to help open up the carpal tunnel and relieve the pressure on the median nerve. Alright, as a quick recap, carpal tunnel syndrome is a condition most often characterized by a numbness and tingling in the hand caused by a compressed median nerve in the wrist, and if necessary can be surgically treated by release of the transverse carpal ligament, which forms the roof of the carpal tunnel. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.
Herb Duchenne palsy is named after the neurologists Wilhelm Herb and Duchenne de Boulogne, who first described it. In this disorder, there's paralysis to the muscles of the shoulder and the upper arm, and it happens when the nerves that innervate these muscles are damaged. People with this disorder have their arms stuck in a position that looks like a waiter discreetly trying to get a tip, so it's called waiter's tip deformity. Okay, so the nervous system has two parts: the central nervous system, which consists of the brain, brainstem, and spinal cord, and the peripheral nervous system, which includes all of the nerves that fan out from the central nervous system. Broadly speaking, the nervous system is split into an afferent and an efferent division. The afferent division brings sensory information from sensory receptors in the peripheral nervous system to the central nervous system, and the efferent division sends motor information from the central nervous system to organs like skeletal muscles, which causes them to contract. Now, part of the peripheral nervous system are spinal nerves, which branch off the spinal cord. There are 31 pairs of spinal nerves, which are grouped into 8 pairs of cervical nerves, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, 5 pairs of sacral nerves, and 1 pair of coccygeal nerves. The brachial plexus is a network of spinal nerves that innervate the shoulder, arm, and hand by supplying afferent or sensory nerve fibers from the skin, as well as efferent or motor nerve fibers to the muscles. In terms of anatomy, the brachial plexus is divided into 5 roots, which come from the last 4 cervical nerves, C5, C6, C7, and C8, as well as the first thoracic nerve, or T1. The 5 roots will then combine to form 3 trunks. C5 and C6 merge to form the superior or upper trunk, C7 remains as the middle trunk, and C8 and T1 merge to form the inferior or lower trunk. These trunks then form 6 divisions, which will regroup with each other to form 3 cords. These cords give multiple branches. The main 3 are the musculocutaneous nerve, which is made up of contributions from C5, C6, and C7, the axillary nerve, which is made up of contributions from C5 and C6, and the subscapular nerve, which is made up of contributions from C5 and C6. Herb Duchenne palsy happens when there's an injury to the C5 or C6 roots, or to the upper trunk that contains nerve fibers from these roots. This injury commonly occurs in infants during labor, in a condition called shoulder dystocia, which is when the baby gets stuck in the birth canal and when one or both shoulders become trapped against the bones of the maternal pelvis. When the baby is pulled out, the force could cause damage to the shoulder and the nerves in the brachial plexus. Although most common in infants, Herb Duchenne palsy could affect people at any age when there's shoulder trauma. Okay. Let's look at what happens when someone gets this condition. First, the axillary nerve innervates the deltoid, which acts to abduct the arm, moving it away from the trunk. So when the axillary nerve is damaged, the arm hangs by the side of the body. Next, the musculocutaneous nerve innervates the biceps brachii, which flex the arm at the elbow joint and supinate the forearm, turning the palm anteriorly. So when the musculocutaneous nerve is damaged, the arm extends straight at the elbow joint and the forearm stays pronated, turning the palm of the hand posteriorly. Finally, the suprascapular nerves innervate the supraspinatus muscle, which helps the deltoid in abducting the arm, and the infraspinatus muscle, which acts to laterally rotate the arm, moving it away from the midline of the body. So when the suprascapular nerve is damaged, the arm cannot abduct and rotates medially, or towards the midline of the body. When combined, we have what's called waiter's tip deformity, where the affected arm is adducted and medially rotated, while the forearm is extended and pronated. This gives the appearance of someone subtly asking for a tip, thus the name. All 3 nerves also carry sensory information from the skin of the arm, so it could also cause loss of sensation in some cases. Finally, loss of innervation to the muscles in early life causes them to shrink, leaving the affected arm smaller and weaker than the unaffected one. The diagnosis of Herb Duchenne palsy is based on the history of damage to the affected arm and on physical examination to evaluate the appearance and function of the affected muscles. Treatment isn't needed in all cases of Herb Duchenne palsy. Most babies recover within the first year, but others develop permanent arm weakness or paralysis. Physical therapy is often used to aid in the recovery process. However, if Herb Duchenne palsy does not resolve, surgical procedures like nerve transfers from the opposite healthy arm can be done. Alright, as a quick recap. Herb Duchenne palsy occurs when there's a disruption of the innervation to the muscles of the shoulder and the arm, caused by an injury to the nerve roots C5 or C6, or to the upper trunk of the brachial plexus. The most common symptom is waiter's tip deformity. Herb Duchenne palsy is diagnosed by a physical exam and is treated with physical therapy and surgery.
Klumpke's palsy, named after the neuroanatomist Auguste Desjardins Klumpke, who first described it, is where there's muscle paralysis in the hand, caused by nerve damage. This causes all the fingers to stay in a flexed position, so it's also called total claw hand. Now, we have 31 pairs of spinal nerves which branch off the spinal cord. These are grouped into 8 pairs of cervical nerves, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, 5 pairs of sacral nerves, and 1 pair of coccygeal nerves. Now, some of the cervical and thoracic nerves form the brachial plexus, which is a network of nerves that controls the muscles and sensations in the shoulder, arm, and hand. In terms of anatomy, the brachial plexus is divided into 5 roots, which come from the last 4 cervical nerves, C5, C6, C7, and C8, as well as the first thoracic nerve, or T1. The 5 roots combine to form 3 trunks. C5 and C6 merge to form the superior or upper trunk, C7 remains as the middle trunk, and C8 and T1 merge to form the inferior or lower trunk. These trunks then form 6 divisions, which will regroup with each other to form 3 cords. These cords give off 5 terminal branches. The main 3 are the median nerve, which is made up of contributions from C5, C6, C7, C8, and T1, the radial nerve, which is also made up of contributions from C5, C6, C7, C8, and T1. And finally, the ulnar nerve, which is made up of contributions from C8, T1, and occasionally C7. Klumpke's palsy occurs when there's a stretch or tear at the C8 or T1 roots, or at the lower trunk. This happens when an abducted arm is pulled further away from the body. In infants, this could happen when the baby is pulled out of the birth canal by the arm during delivery. In adults, a trauma to the shoulder, like when someone tries to grab a tree branch while falling, can cause the nerves to be torn. This leads to dysfunction of the median and ulnar nerves since they contain fibers from these roots. Okay, so if we look at the effects of the nerve damage, in the forearm, the ulnar nerve innervates the flexor carpi ulnaris, which controls the muscles that flex the wrist. So when the ulnar nerve is damaged, it causes the wrist to stay extended. On the other hand, the median nerve innervates pronator teres and pronator quadratus, which pronate the forearm, turning the palm posteriorly. So, when the median nerve is damaged, the forearm stays supinated, meaning that the palm of the hand faces anteriorly. Now, moving on to the hand. The median nerve innervates the thenar muscles, which control the movements of the thumb, so thumb movements are limited. Similarly, the ulnar nerve supplies the hypothenar muscles, which control the little finger, the interossei muscles, which abduct and adduct the fingers, meaning to spread or bring them together. So, an injury to the ulnar nerve causes a loss of movement of the little finger, and the inability to abduct or adduct all 4 fingers. Finally, both the ulnar and median nerves innervate the lumbricals, which are 4 muscles that extend the fingers at the interphalangeal joints, and keep them flexed at the metacarpophalangeal joints. On the contrary, muscles of the forearm oppose the action of the lumbricals. These muscles include the flexor digitorum profundus, which flexes the fingers at the interphalangeal joints, and the extensor digitorum, which hyperextend them at the metacarpophalangeal joint. When the ulnar and median nerves get damaged, muscles in the forearm override the action of the lumbricals, causing the hand to look like a claw. So, with Klumpke's palsy, we end up with a person whose forearm is stuck in the supinated position with the wrist extended. The fingers are flexed at the interphalangeal joints and can't abduct or adduct. Now, both nerves also carry sensory information from specific areas of the hand to the central nervous system. Damage to the median nerves could result in numbness in the thumb, the index finger, and middle finger, as well as half of the ring finger that's on the thumb side. The other side of the ring finger and the pinky are innervated by the ulnar nerve. Finally, the first thoracic nerve root, or T1, provides sympathetic innervation for the head, neck, and eyes. When this nerve is injured, it causes Horner syndrome, which is a triad of 3 symptoms: miosis, or constricted pupil, ptosis, a droopy eyelid, and anhidrosis, the inability to sweat. Sometimes, Klumpke's palsy gets confused with another condition called thoracic outlet syndrome. Thoracic outlet syndrome is a group of symptoms caused by compression of the brachial plexus and the subclavian artery and vein as they travel through the narrow space between the collarbone and first rib, called the thoracic outlet. This compression could be caused by a cervical rib, which is a congenital anomaly where an extra rib is located above the first rib, or by a Pancoast tumor, a type of lung cancer where a tumor forms at the tip of the lung. Overuse of the shoulder and arm can cause inflammation and swelling in the area, which also narrows the thoracic outlet. Whatever the cause, compression of the inferior trunk and roots of the brachial plexus causes similar motor and sensory symptoms in the arm and hands as Klumpke's palsy. Horner syndrome can be present if T1 is affected. In addition, compression of the subclavian artery decreases blood supply to the arm and hand muscles, causing pain and atrophy. Compression of the subclavian vein decreases blood drainage from the arm and hand, leading to edema. The diagnosis of Klumpke's palsy and thoracic outlet syndrome is based on physical examination to evaluate hand and forearm weakness. Advanced diagnostic techniques like electromyogram and nerve conduction studies may be used to further investigate if the motor symptoms are due to damaged nerves. If thoracic outlet syndrome is suspected, a chest X-ray or MRI could be ordered to identify the cause of the compression. Treatment of Klumpke's palsy largely focuses on physical therapy, which involves exercises that help recover strength and improve the range of movement. Despite this, some people will develop permanent hand weakness or paralysis. For thoracic outlet syndrome, anti-inflammatory medication can be given to decrease swelling and help manage the pain. If the compression is caused by an extra rib or a tumor, surgical removal is the best option. Alright, as a quick recap, Klumpke's palsy occurs when there's a disruption of the innervation to the muscles of the hand, caused by an injury to the nerve roots C8 or T1 or to the lower trunk of the brachial plexus. The most common symptom is weakness or paralysis in the intrinsic muscles of the hand, causing the hand to flex into a claw. Horner syndrome could occur when the T1 nerve is affected. These symptoms also occur in thoracic outlet syndrome, where the same nerves as well as the subclavian artery and vein are compressed as they travel through the narrow space between the first rib and the clavicle. These two disorders are diagnosed based on physical exam, although imaging studies might be needed for thoracic outlet syndrome. Physical therapy plays a big part in the treatment of both disorders, but surgery might be needed in certain cases of thoracic outlet syndrome.
The rotator cuff refers to a group of 4 muscles and their tendons, which help to stabilize the shoulder when it's moving, particularly during rotational motion. So, a rotator cuff tear is when one or more of the tendons of the muscles of the rotator cuff are torn. The shoulder is a complex of bones, ligaments, muscles, and their tendons that all work together to connect the upper limb to the chest, allowing necessary movement and providing stability. The round head of the humerus fits and rotates inside the shallow glenoid cavity of the scapula. Just above the glenoid cavity, the scapula extends 2 bony processes, the acromion and the coracoid processes, which serve as attachment for ligaments and muscle tendons. The ligaments of the capsule of the glenohumeral joint hold the head of the humerus inside the glenoid cavity. The coracoacromial ligament forms an arch between the coracoid process and the acromion, and it prevents the head of the humerus from upward dislocation. In addition to these ligaments, the shoulder is supported by the 4 rotator cuff muscles, also called the sits muscles, for supraspinatus, infraspinatus, teres minor, and subscapularis. The sits muscles form a cuff that surrounds the head of the humerus to make it stable and help it move, specifically in abduction as well as internal and external rotation. Below the acromion lies the acromial bursa, which is a small sac filled with rubbery synovial fluid that provides lubrication and prevents the rotator cuff tendons, especially the supraspinatus tendon, from rubbing against the acromion as the joint moves. A rotator cuff tear may occur when the tendons are violently stretched, like when you jerkily lift up something which is too heavy, or accidentally fall on an outstretched arm. This most commonly affects the supraspinatus tendon at its insertion on the greater tubercle of the head of the humerus, because it's under a lot of tension when the shoulder is abducted. Now, the tears may be partial, which is where the tendon is damaged but not completely torn, and may even go unnoticed. Alternatively, the tear may be a full thickness tear, where the tendon is completely detached from the humerus. In contrast to an acute tear, there may also be a chronic tear due to regular wear and tear, which usually occurs in the elderly. That's because the blood supply to the rotator cuff tendons reduces over time, making it harder for them to heal after an injury. As a result, injuries can go unrepaired, and successive injuries can weaken the tendon. A classic example is when the shoulder is used to repeat the same motion over and over, like for a pitcher in baseball. Chronic tears can also occur where the bones overgrow, specifically where there may be a bone spur coming off of the acromion that rubs the rotator cuff tendons during shoulder abduction. This condition is called shoulder impingement. In an acute tear, there can be an intense shoulder or upper arm pain, whereas in a chronic tear, the pain might be absent, or only occur when using the affected shoulder. The affected shoulder may also be weak, specifically with abduction or rotation. The diagnosis of a rotator cuff tear mainly relies on testing the arm's range of motion and strength, and any associated pain. An X-ray may identify the presence of abnormal bone spurs on the acromion, or if the space between the head of the humerus and the acromion is narrowed. An MRI can visualize the torn tendon and identify if it's a partial or complete tear. The treatment of a rotator cuff tear begins with ice to reduce inflammation, pain medication, and rest, with gentle physical exercise to prevent stiffening. In more severe cases, open or arthroscopic surgery may be needed to repair the torn tendon. Alright, as a quick recap. In rotator cuff tears, one or more tendons of the sits muscles, supraspinatus, infraspinatus, teres minor, and subscapularis, of the rotator cuff are torn. Acute tears happen when the tendons are violently stretched, like falling on an outstretched arm. Chronic tears result from cumulative wear and tear on the tendon, and it usually occurs in the elderly. The diagnosis basically is mainly based on pain and weakness, specifically with the abduction or rotation, and can be confirmed with an MRI. Treatment involves rest, ice, and pain control, but if that fails, surgery may be needed.